This week on the BackTable podcast.
The issue with embryo freezing versus egg freezing is that many patients are not with that same person when they want to use those embryos in the future.
Yeah.
So when I went back and looked, I had a database of fertility preservation patients that was about 20 years from my former institution. And we went back and looked at those patients that froze embryos. And we identified that about 15% of those patients were no longer in a relationship with the people they made the embryos with.
That is fascinating.
It was actually one of my fellows' research projects. And I've seen many patients, unfortunate situations where they come back to see me, after having cancer treatment and being a survivor, but they're no longer with the person they made the embryos with.
Welcome back to another episode of BackTable OBGYN. This is Amy Park, and I am so honored and pleased to have one of my colleagues here, Dr. Mindy Christianson. She is the section head of Reproductive Endocrinology and Infertility at the Cleveland Clinic, the practice director of the Cleveland Clinic Fertility Center, and the program director of the REI Fellowship. She trained at the University of Wisconsin for both her undergraduate and medical school, and then trained at Johns Hopkins for both residency and fellowship, and then also obtained her MBA there. She also is a fellow of the ELAM program currently. What is your project for ELAM, by the way?
So I'm actually starting a multidisciplinary fertility preservation program, the Cleveland Clinic Center for Fertility Preservation and Restoration.
Oh, that's awesome. Well, that's a good segue to the topic that we are going to be discussing today, which is fertility preservation. So tell me how you got interested in this topic.
So I actually became interested in fertility preservation at the same time I became interested in going into OBGYN. I was a third-year medical student, and I was on the infertility rotation. I was the only medical student, and there were no residents around, so I was very active in the clinic. And a patient came in, and she was a young patient with breast cancer. And I actually had attended undergraduate with her, so I knew her.
What? Oh my gosh!
And she was about to get married, and she ended up freezing embryos prior to getting married. And then she had her breast cancer treatment, and then her sister was actually her gestational carrier. So it was a beautiful story, and it was something that just really I fell in love with the subspecialty and the wonderful things you can do.
That's awesome. Yeah, REI is such a joyful profession in that you help them in their journey. It's also, I think, very disappointing for patients who, for the most part, a lot of them are very successful patients, and then, in their careers, et cetera, and then not having control over their bodies. It's and this thing that they really, really want to achieve in this endeavor. I'm sure you're very used to taking people along those journeys. But the fertility preservation is a particularly, how shall I say, it's even more fraught journey, just because the circumstances under which you're discussing fertility preservation have more consequences than most. Tell me, how do you define fertility preservation in this day and age, and what are the most common patient groups you're seeing people seek this for?
Yeah, so fertility preservation is a really broad term. It's really the preservation of eggs, embryos, ovarian tissue, or other material, reproductive materials, sperm, testicular tissue, so that in the future, someone can use that to have a biological child. So that's really the main definition, and there's many different ways that you can move forward with fertility preservation. I would say the biggest group of patients that we're seeing are actually young women that are doing what we call planned fertility preservation. And that's people who are delaying their family building until later in life. And they know that if they wait until they're later in life, their chance of pregnancy will be much lower due to their egg supply and egg quality. So they're freezing their eggs at a younger age. So that's the biggest group of people we see. But I also see many, many patients prior to cancer treatment and other types of treatments that can harm their fertility.
I always joke, I'm getting older, but all of the residents and fellows stay the same age. But I've been surprised at how many of them are really pursuing egg, oocyte cryopreservation, et cetera. This is a physician-facing podcast, so I'm sure a lot of our listeners are confronting these choices. What do you think is prompting it? Just single status of this patient population in terms of the oocyte cryopreservation?
Well, I mean, I think when we look at young physicians or young professionals, but especially physicians, because there's so much usually of a delay in family building, because there's your undergraduate, your medical school, your residency, fellowship. So there's a lot of training that can delay the actual attempts for family building. And so this is a group that we know will have decreased fertility outcomes as they get older, but they're also recognize the importance of medical procedures such as egg freezing, which can help preserve their fertility. So that's definitely one of the biggest groups of patients that I see.
Yeah, and then the cancer patients, it seems like it's just the prevalence and incidence of young onset cancer seems to be increasing. What you're describing in terms of the breast cancer, I was talking to Bala, our friend at Wisconsin. He was saying he sees a couple of these patients a month. I mean, Is there an increase in young breast cancer, or is it just that they're seeking more fertility preservation? I don't know.
Well, I mean, I think we definitely see many patients. I see probably 2 patients a week of breast cancer patients for fertility preservation consultation. And also a bigger group we're seeing right now is colorectal cancer in younger patients. I think a lot of it is there's earlier diagnosis and people are more cognizant, but we're definitely seeing more. And it might be also that oncologists are more likely to refer patients.
Yeah, what are the indications that should prompt a referral for fertility preservation counseling?
So any patient that's going to undergo a treatment that can be harmful for their fertility. And so obviously cancer treatments such as chemotherapy, radiation to the pelvis would be treatments that can be very harmful for fertility for a female, but also a breast cancer patient that needs to undergo hormonal suppression for 5 to 10 years. This is a patient, even if she's not undergoing chemotherapy, that would benefit from fertility preservation since there'll be a delay for when they can actually carry a pregnancy.
Do we know the outcomes of all of the hormonal stimulation, and then suppressing it? Have we seen any impact on their breast cancer outcomes, or it doesn't really matter?
So what we're able to do is we can actually add the medication letrozole, which is used for breast cancer hormonal suppression because it keeps the blood estrogen levels low, but we actually use it off-label. It's probably one of the most popular medications that REI physicians use. We use it off-label for ovarian stimulation. So we can add that medication to the IVF stimulation and it keeps the blood estrogen levels low. So it's actually makes it much safer for patients who are estrogen or progesterone receptor positive.
That is interesting. Well, can you walk us through what you typically go through in a consultation with a patient who's exploring egg or embryo freezing or testicular? I mean, I guess you're more on the female side, but obviously it's also happening with our urology colleagues on the male side.
Yeah, so I think the consultation itself is a little bit different if it's a cancer patient or a patient for medical fertility preservation versus someone who's doing planned fertility preservation. So it's a little different. So for the medical fertility preservation or oncofertility, these patients we will see within 2 business days of the request for the consult. So we'll see them right away. And, at that visit, decisions have to be made fairly quickly and treatment needs to start off often like within a few days. So at that consultation, we usually, before the consultation happens, we try to order an AMH level right away. So the person who orders the consultation, they're instructed to order the AMH level. So we actually have that result at the time. So there's different ways that we can measure ovarian reserve or someone's egg supply. And one of the most convenient ways today is with the AMH level because it's a blood test that we can do at any time during the menstrual cycle. And we use the AMH level as a predictor to how people would respond to treatment. So it works really well for counseling someone prior to fertility preservation. So the consultation usually starts with, first of all, like talking about the patient's diagnosis and what the treatment plan is. Oftentimes, the treatment plan is still in flux, so talking about what the possible treatment options would look like. And then we talk about what the risk of their fertility is. And we do have information about their ovarian reserve already, usually with the AMH level, so we can look at their egg supply and their age and the treatment. And chemotherapy is typically going to be categorized according to high risk, medium risk, or low risk. So we can really help predict the chance of the patient having ovarian insufficiency or ovarian failure after the treatment, and kind of talk about those risks first, because sometimes the treatment plan is for something that's lower risk. And so sometimes we may not strongly recommend fertility preservation for the patient, but being able to have the options does help the patient a lot in the long run. So after we talk a little bit about the risks, then we talk about the fertility preservation options. And the three main options that we discuss include freezing embryos, freezing eggs or oocyte cryopreservation, and then freezing ovarian tissue. And the treatment really depends on where the patient is in their family building journey and their age and things like that. So if the patient's choosing to do egg freezing, then we kind of go through the entire process at that visit. So I have slides and pictures, and we go over the whole process with the patient. And then usually if the patient decides that she wants to do treatment that day, we'll submit the treatment plan to our financial counselors and work on getting all of that set up for the patient and ordering medications that the patient often can get for free. And then we can usually start the cycle within a couple days.
What are examples of the highest risk chemo agents? Like, it sounds like, I know we talked about a couple weeks ago, the 16-year-old with lupus who is about to start cyclophosphamide. I'm assuming cyclophosphamide is one of the high risk agents?
Yeah, so the agents that are the highest risk for fertility are the alkylating agents. And alkylating agents directly damage DNA, so they're great for killing cancer cells, but unfortunately they're also very destructive to eggs and other rapidly growing tissues. And so they're going to be the most damaging. And so cyclophosphamide is really known as one of the alkylating agents that's the most damaging, is the one we have the most research on. It's a mainstay medication for breast cancer in many situations, sarcoma. It's used sometimes for Hodgkin's lymphoma. Now we have some alternative treatments, but it's used a lot for Hodgkin's lymphoma. And then it's also used widely for any patient undergoing a bone marrow transplant or a stem cell transplant.
Yeah, that's a lot of younger patients undergoing those bone marrow transplants too. And then how about the patients who are wanting the planned fertility preservation, they're single in their 30s, for example? How do you counsel those patients?
That consultation is a little different because we spend a lot of time talking about age and ovarian reserve and family building goals, because it really does vary from person to person. So this is going to be a much more personalized consultation. So a lot of times it might be a 30-year-old resident physician who's coming in for like a fertility checkup. I want to know what my egg supply is and what my options are.
Yeah.
And if I'm going to freeze my eggs, when I should do it, or should I be doing it now, or can I do it later? So it's really like forming a timeline for the patient. And so that will include an AMH level or anti-Mullerian hormone levels, part of the evaluation, and then an ultrasound to look at the ovaries and antral follicle count. So those are the main things that we'll start with. But then a lot of it is just talking about egg freezing. And in general, we recommend that someone freeze their eggs before the age of 35 if they can. But if the patient has a lower egg supply than we would expect for her age, then we would potentially recommend doing egg freezing sooner rather than later. So we take that into account.
Can I just ask two questions? One about, explain to me AMH, because it's funny, I'm showing my age. I know AMH has been around a long time, but when I was doing residency over 20 years ago, AMH was not a thing. So I know people are like, don't order the AMH just to check the, fertility, because you get a lot of consults about the AMH, but it is a predictor of outcomes. So how should people be using it? Only in the setting of the, if they're planning on doing fertility preservation? Because sometimes it gets checked just to check, I think, is my impression. I don't know.
Yeah, so I think that really varies. And some of us have strong opinions. And so when I first started in my current group, not everyone was ordering AMH levels for infertility patients, whereas I order AMH levels for anyone who walks in the door. I think it's important to know. And so there's no reason to not know what your AMH level is. You should know what it is. And the AMH level is just important to understand. It's not a predictor of fertility in the general population. it's a predictor of response. And so if I was possibly going to be freezing my eggs, I'd want to know my AMH level sooner rather than later. And just to know like when I should do it, or maybe I can wait a little bit. So I think it's a really helpful lab value to have.
So how about, oh my gosh, I don't know what it's called, hypogonadic hypopituitarianism or whatever it is, where you're stressed out as a resident, and can your AMH level be terrible and then all of a sudden you're less stressed out in fellowship or as an attending and it bounces back? Or is it dynamic and flexible, or is this like once it's bad, it's really bad?
So one of the great things about AMH is that it's reflective of your egg supply. It's reflective of the ovarian follicular pool. And so that's what it tells us about. And so it has nothing to do with the hormones that can get people stressed out. So someone who has amenorrhea from various reasons, if they have hypothalamic amenorrhea, they can still have a good AMH level. And so it's just a good value to know what their AMH level is. Now, if someone's on a birth control pill for an extended amount of time, that can artificially drop the AMH level a little bit. If I see a patient who's on a birth control pill, I'll still check the AMH. And if it comes back lower than I would expect, then I would have the patient, if she were willing to do that, take about a six-week washout period or stop the birth control pill for about 6 weeks and then recheck the AMH level. But if someone has a good AMH, even if they're on the birth control pill, then that's reassuring.
What if we have a fellow who did, their oocyte cryopreservation in residency, her AMH levels were terrible, but then now she's partnered up. Should she be like hustling and pressuring her boyfriend, or should she just like be like, okay, well, I know my AMH level was bad in residency, but I think it's, I don't have the time for it now. I mean, I'm just wondering. I'm not in that situation, but you know what I mean?
Yeah, no, so I think that's important, because even if someone freezes their eggs, it's not necessarily like the minute you want to get pregnant that you thaw your eggs to use. It's more of an insurance policy that you can use for the future. And so if there's a resident that has like a low AMH level, but they're 32 or 33, they still have excellent egg quality and they still have an excellent chance of conceiving every time they ovulate if they're trying to conceive. And so they should just probably try to conceive if that's important to them to do, and it's at a good time in their life to do. Otherwise, they have their frozen eggs.
So, way back when oocyte cryopreservation was starting, I remember ASRM and ACOG labeled it experimental and really were pushing embryos. And obviously, you need some sperm to get some embryos. And it sounded like the mitochondria did not survive the vitrification and thawing process. Has the technology advanced since then so that it's got a higher success rate? Because I think at the time that it was like over 20 years ago probably, or maybe around 20 years ago, it was only 15% yield for pregnancy.
Yeah, so what's interesting is that we've been freezing embryos for like 30 years. We've been freezing embryos for a long time. Embryos are really easy to actually freeze and warm. But eggs are actually much harder to freeze. And that's because the egg is the largest cell in the human body and it has the most cytoplasm, so it has the most water. So ice crystals can form. And so the original freezing technology that was used for embryos that was attempted for eggs is called slow freezing. And the idea with slow freezing is that with that technique, you can prevent the ice crystals. And so the original egg freezing was slow freezing. It wasn't until the early 2000s that a type of freezing was invented called vitrification. So vitrification didn't come around until the early 2000s. And then with vitrification, it became very successful for eggs. And so I actually was a resident when vitrification was becoming popular. And one of my research projects as a resident was to compare frozen eggs from patients who had froze their eggs for cancer and compare the eggs that were frozen from slow freezing to those that had been vitrified to see if there was like a difference in the survival rate as well as the DNA. And there was this big difference, obviously, between the slow freezing and the vitrification. So it was really vitrification, which is what has made egg freezing much more efficient. And so in 2012, it was finally announced by ASRM, the American Society for Reproductive Medicine, that egg freezing is no longer considered experimental. So that's really when we've seen the rate of egg freezing increase 800%, I believe. A huge increase.
Yeah. Well, a couple of the other accolades that I did not mention about Mindy is that she is on the board of ASRM. Are you the president or past president of Society of Reproductive Surgeons?
I'm the past president of the Society for Reproductive Surgeons. I'm not on the board of ASRM anymore, but I'm now on the board of SART.
Okay. She's on the board of SART. And then, which is
the Society for Assisted Reproductive Technology.
Yeah. And then SART also has all those stats on fertility, success rates of IVF, et cetera, right?
Correct.
Yeah. And then also a professor at Cleveland Clinic, Lerner College of Medicine of Case Western University. So it sounds like you started the REI journey quite early, medical school and residency. It sounds like it really sparked your imagination. It is a really cool intersection between the science and the clinical because, all of these techniques came out fairly recently in the last 20, 25 years, it seems like. But anyway, what is an optimal age to freeze eggs? You just alluded to egg quality. I just read an article up in the New York Times about how 35, is this big number, but it's not like this cliff, the sudden cliff. It's more the age at which it was rooted in the risk of amnio, I think, and testing for genetic stuff. But what would you say are your counseling in terms of age and fertility?
Yeah, so the optimal egg quality is in the early 20s, but you've had you're born with a set number of eggs. The number of eggs goes down over time. Most females will have about 1 million eggs at birth, and that number goes down over time. Because you've had these eggs since before you were born, and every time you ovulate, the eggs have to divide one more time. As someone gets older, they're more likely to have an egg after ovulation that's chromosomally abnormal because the DNA becomes more sticky as you get older. So you're more likely to have a chromosomally abnormal egg. And so usually it is after the age of 35 that we'll see a higher rate of chromosomally abnormal eggs, but it really doesn't start to significantly increase until after the age of 37. So actually 37 is really the age where we'll see a bigger drop. And so when we look at the studies that have examined the benefit of doing genetic testing of embryos, it's really the most beneficial for people who are 37 and above, because that's when you're going to be able to really increase the chance of live birth and decrease the risk of miscarriage with genetic testing of embryos.
And then when you discuss the egg versus embryo cryopreservation, what clinical or personal factors guide your recommendations?
So today I'm unlikely to really recommend embryo cryopreservation unless it's a patient who was actively undergoing IVF when she was diagnosed with breast cancer, or she was already an infertility patient or maybe has children already. Then I'm more likely to recommend embryo freezing. The issue with embryo freezing versus egg freezing is that many patients are not with that same person when they want to use those embryos in the future.
Yeah.
So when I went back and looked, I had a database of fertility preservation patients that was about 20 years from my former institution. And we went back and looked at those patients that froze embryos. And we identified that about 15% of those patients were no longer in a relationship with the people they made the embryos with.
That is fascinating.
Yeah. And it was actually one of my fellows' research projects. And I've seen many patients, unfortunate situations where they come back to see me, after having cancer treatment and being a survivor, but they're no longer with the person they made the embryos with. Because a lot of times especially before egg freezing became established, they were making embryos with their boyfriends or whoever they weren't maybe not even in that long of a relationship, but because egg freezing wasn't considered established at that time. And also, if someone's in a relationship and there's an early cancer diagnosis, they're less likely to have a breakup at that point, but later on they may. And so it's about 15%. And so because of that, even if someone's in a relationship, I'll encourage half embryos, half eggs.
That's fascinating. Wow. Yeah, I remember that famous case with Sofia Vergara and her former husband, and they litigated. But I think that litigation, you're right, is actually fairly common about whether or not they can use the eggs or the embryos after divorce or after splitting up.
Mm-hmm.
you're like, yeah.
Yeah, so it's really, I have not seen a case of one of my cancer patients who's come back not in a relationship where the guy has like signed off the full rights of the embryos to her.
Okay, got it.
That has yet to happen.
Yeah, that's interesting. And then, well, what are the stats that you quote for success of live birth with oocyte cryopreservation?
So we don't have as much data with egg freezing. We're actually just finally going to have some data from SART coming out in the next year, which I think will be really good to have that data. Because first, a lot of cancer patients are not coming back right away to thaw their eggs. And we're looking at egg freezing was just considered no longer experimental in 2012. And so we don't have a lot of data from people even doing planned egg freezing. Most of the data we have is from egg donors. And so from the creation of donor egg banks. And so when we look at that data, it's actually very good data. So usually if someone has like 6 frozen eggs from an egg donor, they have an excellent chance of having 1 to 2 high quality blastocyst embryos. So we can look at that data, and there's some other data. You just have to be careful because some of the research studies were from when we were first freezing eggs when we weren't as good as we are now. But in general, I recommend a patient who's under 35 to freeze about 20 eggs. And 20 eggs should be enough to have about 2 children, hopefully. So it really depends on the patient and her age and her family building plan.
Yeah, you alluded to SART. I was in conversation about fertility a couple of weeks ago, and it's interesting because all of that is publicly identified data through SART and CDC, correct?
Mm-hmm.
Yeah. Well, anyway, tell me, how has the collaboration between oncology and REI evolved over the years, and where the gaps still exist? It sounds like breast cancer, colorectal cancer, oncology, gyne-oncology. Is there like a heightened awareness now?
So I will say that when I first started working in fertility preservation, both at Cleveland Clinic and at my former institution, that I was most impressed with pediatric oncology. Pediatric oncology really identified the importance of fertility preservation counseling early. And so they were very proactive about developing programs to offer fertility preservation to patients. And even today, I think my closest collaboration is still with pediatric oncology. I mean, I feel really confident that any patient at the Cleveland Clinic who's a pediatric patient will be offered a fertility preservation consultation if they're at high risk. And so they've been very good about developing programs, identifying patients, having navigators. We have a very strong navigator program at the Cleveland Clinic, which is amazing. And so with pediatrics, with Kara Bendel, who's our program manager. So we have a really strong pediatric program. And so that's been very easy. And then when we look at the adult cancers, it's interesting because each cancer is like its own separate department or its own separate clinic. And so breast has obviously been, because that's it's really our biggest cancer patient group. So breast is very proactive about referring patients to us. And most breast cancer programs will have a designated fertility preservation navigator to make sure people have early referrals. I would say that colorectal is as well, but then after that, it really varies. It's going to be up to the individual oncologist. And it's really the responsibility, I think, of the fertility preservation program to educate oncologists about what we have to offer and how to get patients appointments to make it as easy as possible. Because just since I've been at the Cleveland Clinic, our consultation numbers have doubled just by making people more aware.
That's amazing. You bring up the pediatric oncology population, and I just wanted to ask about the prepubertal patients. How are you able to help them with their future fertility journeys?
So one of the most exciting things about fertility preservation for pediatric patients is the evolution of ovarian tissue cryopreservation.
Yeah.
Which has been around for about 20 years. And so it's a young technology because the patients are just starting to come back now to use the frozen ovarian tissue. And so there have been at least 300 live births to date from frozen ovarian tissue, but we don't know the exact number because unfortunately there's not a registry worldwide or in the United States. So we really don't know. I, at the Cleveland Clinic, recently did my first ovarian tissue transplantation of a patient who froze their ovarian tissue 17 years ago.
That's amazing. I do remember this because I remember Dr. Falcone was doing this in sheep. And then I remember Veronica Gomez-Logo, and she was at NIH and Children's National was talking about doing this for the pediatric oncology patients and the fertility preservation. But yeah, that's incredible. So now they're ready. They're probably in their 20s or 30s right now.
Yeah, so now all of these patients are ready. And so we have a larger influx of patients that want to transplant their tissue. And so this is not a known established medical procedure. And so we don't have a CPT code. And so it's hard to get insurance authorization and things like that. And so we're just really working to improve access because it's amazing when you transplant this tissue, after about 60 days, it starts to develop its own vascular supply and it starts to function. And so it's really amazing.
So technically, what do you do? Do you just peel off the ovarian cortex in these prepubertal patients and then freeze them and then re-implant them on the ovary, or you put them in the forearm, or how does that work?
Mm-hmm. So today what we're doing is we're removing an entire ovary. When I first started doing this, when I was actually a fellow, so it was like in the 2010, 2012, 2013, we could only remove part of the ovary, so like a 1 centimeter wedge, because it was still considered experimental. It was in 2019, it was announced that ovarian tissue freezing is no longer considered experimental. But today what we do is remove an entire ovary. The reason we do that is because it's faster and it's safer. And typically for pediatric patients, we'll piggyback this with the port placement. So they're already under general anesthesia for their port placement. So then either our team or pediatric surgery will do the harvest of the ovarian tissue. And then we have a courier system set up that then transports the tissue, if the patient's at the main hospital, to our IVF lab where we freeze the tissue. And in the lab, we'll dissect the ovarian cortex off the outside of the ovary and we freeze it in little strips. And then the strips of tissue in the future can be thawed and transplanted back. Attempts have been made to transplant the tissue into the forearm or the axillary area, and you'll have functioning ovarian tissue. It'll make estrogen, but to date, there have been no high quality eggs that have been retrieved from that attempt to create embryos. And so it has to do with the temperature differential of that part of the body. So it's not the ideal place. And so optimally, what we'll do today is we'll transplant the tissue on the existing ovary if they have an existing ovary, because it's anatomically in the correct place. And so the patient could actually have an unassisted pregnancy versus IVF. If the patient doesn't have both ovaries, we can also transplant it into the ovarian fossa and make a window in the peritoneum. So that's the other option.
Oh, does it cause that ovarian remnant syndrome? Like when they ovulate into the peritoneum, does it hurt them or something, or not really?
It's open though. So we transplant it into the peritoneum like in a little window, but it'll ovulate, it'll be released into the pelvis. And so it's not buried like that, but it is essentially an ovarian remnant that we're putting there. We're transplanting there and it's functioning like that. But when it ovulates, because it's on the outside, it will be released into the pelvis.
Well, tell me, what are some other exciting future directions or experimental or near future technologies? Because I know you and the oncology team did a really cool uterine transposition case. And then I know there's been oophorexies, PEXIs, to take the ovaries outside of the radiation field. But tell me a little bit more about those kind of surgeries or technologies coming up.
Yeah, so for the longest time for oncofertility, we've been focusing on the ovary and the damage of chemotherapy and radiation to the ovary. And the uterus has been ignored, except if somebody needed to have a hysterectomy. But radiation is actually known to be very damaging to the uterus. It causes fibrosis of the myometrium. It compromises the vascular supply, and it directly damages the endometrium. And so because of that, there are very few reported cases of women who've received pelvic radiation that have been able to carry a pregnancy. So if we have a patient who has, let's say she has colorectal cancer and she needs to have radiation, her option, if she chose to freeze eggs or embryos, would be to most likely use a gestational carrier. In 2017, a type of surgery was invented or reported that's called uterine transposition. And so that's moving the uterus out of the pelvis completely and placing it in the abdomen, the upper abdomen, to protect the uterus from the radiation field. And the first live birth, I believe, was reported in 2022 or 2023, so very recently. And since then, there's been a handful of live births. And we were very excited to recently do what we believe is the first straight stick laparoscopy procedure in which uterine transposition was done. And we did that at the Cleveland Clinic with that patient with colorectal cancer. So her uterus is actually still currently transposed. It will be returning it to her pelvis soon when she's done with radiation.
I wish we could share a visual, because I know you and Dr. Dina Bernardo were involved in this case, and then you can see the cervix is attached to the umbilicus, and she's going to menstruate through the umbilicus, correct?
Well, she could menstruate. We did give her a GnRH agonist to prevent menstrual cycles, though, as well, and also for protection. But one of the interesting things about this surgery is it's like you're doing a hysterectomy. You're completely going through the uterine arteries, and you're doing a colpotomy, and you're kind of flipping the whole uterus up. And then you could attach the cervix to create an outflow tract or a stoma. And that was first reported actually through the umbilicus with the first case that was done in Brazil. And there's been some institutions that have not done the stoma, but we decided to do it just to prevent the risk of a bowel obstruction if the patient were to have menses or have bleeding, because that could certainly happen. And so it is, and where her radiation field needed to be, we actually had to go up a little bit higher than we normally would. So her cervix is actually anastomosed right above her umbilicus.
Interesting. That's amazing. And then how is that once her radiation is done? I'm assuming the ovaries and the uterus are all in the upper abdomen, and then the plan is to detach it once her radiation is done and then reattach to the vaginal cuff again?
Correct.
And the perimetria?
Correct. Yeah. So I actually have had a patient that we've done this before. Yeah. So, and I forgot to mention, we also transposed her ovaries, but she also froze 30 eggs before we did this too. So she has frozen eggs too, but we did transpose her ovaries out of the radiation field as well. And so the procedure to go back and put everything back. So the main source of the uterus is going to be the ovarian arteries. And so that'll be the main blood supply to the uterus. And so we're not going to reattach the vasculature with the uterine arteries, but we will reattach the cervix to the upper vagina and put everything back. And usually the patient takes about 10 to 12 weeks to recover, but after that, she should be able to have full vaginal function.
Oh, great. Do you recommend C-section for mode of delivery, or vaginal delivery is fine?
So we don't know what the best practices are, because this is such a new technology. So from my review of the literature, all the live births to date have been from C-section, and I would recommend a C-section just kind of given the surgery that the patient's had. And so the plan would be for a C-section, but I am collaborating with maternal fetal medicine to really have some standards and best practices for these types of patients.
Yeah, that's super exciting. Yeah, the picture was pretty cool. And I was curious, how long did the surgery take? Was it 2 or 3 hours? Not too long?
It was not too long. It was about 3 hours.
Yeah.
And honestly, the hardest part was that her ovaries were still enlarged because we had done her egg retrieval the week before. And it was really kind of dealing with the ovaries that were large and had these follicles, and making sure that we could attach them high without the kind of the weight of the ovaries because they were so large.
Oh, interesting. That's cool. Are there any other upcoming technologies that you think are promising?
Well, I think that ovarian tissue transplantation, because all of the live births to date have been transplanting ovarian tissue, that's still evolving. We don't know what the best surgical technique is. And so I think that that's evolving, but that will be much more common, and there'll be many more live births from that. And then another thing that's really ready to become prime time is in vitro maturation. And that is something that in Europe, they do much more in vitro maturation than we do in the United States. But what that involves is taking immature eggs and maturing them in the lab. And so that would allow patients to have faster cancer treatment if it's a fertility preservation patient, because we can retrieve immature eggs and let them mature in the lab. What we can do is if we remove an ovary for ovarian tissue freezing, we can remove the immature follicles first and then mature those follicles and freeze eggs at the same time that we freeze the ovarian tissue. So I think it'll open a lot of doors. There's been some very exciting protocols that have been released that they're mostly doing in Europe that we hope to be able to make more standard in the US.
How about gene editing advances or regenerative therapies? Or, I remember when PGD came out and everybody was like, oh my gosh, PGD is amazing. And now it's pretty standard. Is that sort of it seems like it's always advancing very quickly. I haven't kept abreast of it, but is that something that is a standard option now?
Yeah, so actually, like for patients for sickle cell disease, we've had several patients over the last few months that have done fertility preservation prior to doing their gene therapy for sickle cell, which is really exciting because this is something that will cure them. And the patient herself, though, is her own donor, and it's kind of like she's doing a bone marrow transplant or she's doing a stem cell transplant, because they have to harvest her stem cells and they do the gene editing and then they transplant it back. But the patient has to undergo the same ablative process that's so harmful for fertility. And so the sickle cell patients right now are actually a really important group for us that are undergoing the gene therapy. And these patients are important because sickle cell disease itself brings certain risks. It actually brings a much higher risk when we're doing controlled ovarian hyperstimulation. So we have a special protocol in place to help protect these patients.
Oh, interesting. And then I was going to say that I always read about the CRISPR technology, but I don't know what is exactly the technology that's used for prenatal genetic diagnosis. Is that you have to take a little bit out of the embryo to check it, right?
Yeah, so we just biopsy a few cells from a blastocyst embryo. The embryo at that time should have about 150 to 200 cells. So we just biopsy a few cells and then we send it to an outside lab that amplifies the DNA. And today they're using next generation sequencing for the PGTA, or genetic testing for the chromosomal analysis. And then there's PGTM, which is looking for a single gene mutation. But down the line, there are some companies right now that are already offering whole genome sequencing of an embryo. And so then you can look for multiple mutations at the same time, or abnormalities.
For the gene editing, though, there was a controversy in China, I think, somebody checking for HIV, and then I don't know why, this couple wasn't HIV positive or something. I can't remember exactly what it was. There's always some fertility ethical dilemmas that hit the news every couple of years, but it was something about the gene editing of their embryos. Do you remember this at all, or this is just one of the many scandals?
Yeah, but I do think that will become more prime time. I think right now we're still doing a lot of the gene editing on primates too, but I definitely think that it's something down the line that we'll be able to offer.
How do people afford this? I mean, you said that there's not even CPT codes. Insurance coverage is variable. It sounds like certain states have mandated insurance coverage. Certain states don't. I know we had at the Cleveland Clinic, we have fairly good fertility coverage, but there's some carve-outs, for this, that, and the other thing. What have you heard? You have these national and international physicians, and how are patients dealing with all this? And how is REI meeting the need, I guess?
Yeah, so it's really interesting. So in the United States, there's a handful of states, not very many, maybe around 10 or so, that have state mandates for IVF coverage. And I practiced in one for 10 years. So Maryland has a state mandate for IVF coverage. So that was a much different place to practice than Ohio, because in Maryland, people could literally buy on the open market insurance plans and do $100,000 worth of IVF coverage, and then they could switch to another insurance company. So people were more likely to do multiple IVF cycles. to bank embryos. And even if they had a low ovarian reserve, they could still do multiple cycles. And so it was much more common there for people to do many cycles. Whereas in Ohio, where we don't have an IVF state mandate, there are patients, we really have to maximize their experience. For fertility preservation right now, I believe 19 states that include the District of Columbia have state mandates for fertility preservation coverage. And that's fairly new across the country as far as the state mandate. So right now we're just starting to look at what the implications will be for having a state mandate. But I also practiced in a state that had a state mandate for fertility preservation, and now I'm in a state that does not have a state mandate. So that can make it very difficult for patients. And so I actually do, from time to time, encounter situations where the patient does not have insurance coverage that covers egg freezing, and the patient has to undergo gonatotoxic treatment that will put her at a very high risk for ovarian failure. But unfortunately, even with our compassionate care pricing for egg freezing and being able to get medication for free, the patient can't afford it. And that's just really unfortunate. So we try to do everything we can to have funds available for patients, but it's still very challenging.
Yeah, I know it's so variable. I have friends who live in Massachusetts, which does have a state mandate. And it's just so different practicing there. But how can patients be informed about the emotional and financial aspects of undergoing this process? I mean, cost transparency, number of cycles, long-term storage. I mean, all of these costs do add up over time.
Yeah. So for a cancer patient, we're doing this consultation, talking about the risks of their fertility and talking about also it's a hopeful visit, though, at the same time, because, this patient's been diagnosed with cancer, but we're talking about something happy that could happen for them in the future once they survive. But the conversation always does, at the end, it's going to come down to the financial part. And so I do talk to them a little bit, ballpark about how much it would cost out of pocket with our compassionate care pricing if they don't have insurance coverage. But that, we have our financial counselors will check with their insurance to see if they have coverage. Because more and more companies today are offering fertility preservation coverage. And so even if a patient's in Ohio, if their employer is in another state that has a state mandate, they may have coverage as well. But we do have to have this conversation about the financial aspect. As far as the storage goes, most patients actually, if they're freezing eggs, they can store at our center. I think it's about $500 a year, which is less than a lot of places. But they can also, there's long-term storage facilities, such as a company called Reproductive, where it's much less expensive for a longer-term storage. And so a lot of people will do that as well. But we have to have these financial conversations, because that's what the patients have a lot of questions about. As far as the emotional and psychological toll, what we do know is that patients that are not offered fertility preservation, even if they don't want to have children, but if they're not offered it, and then in survivorship, if they find that they have ovarian failure or premature ovarian insufficiency, that these patients that were not offered the consultation have the most depression, anger, anxiety over the whole process. But patients that have at least been offered fertility preservation, even if they choose not to, are much more at peace with their decision.
That's such a great point. And I think raising awareness is so important regarding referrals. What do you think, if you could just give anyone, this is a physician-facing podcast and mostly OBGYN crowd, but what practical pearls would you give for our audience in terms of, red flags for knowing when a patient should be referred if they have high risk for diminished ovarian reserve, or how to improve access to fertility preservation, or what are things that you've seen that are pitfalls and could easily be avoided?
So I do think it's important for an OBGYN to have a conversation about fertility plans with the patient. And I don't think that they should be afraid to do it. And I don't think they should be afraid to order the AMH level. I think a lot of people are hesitant to order the AMH level because now that they have this result, what are they going to do with it? But I also don't think that you need to refer a patient for an REI consultation to have the AMH level drawn. And so I think it's being comfortable with the AMH level and just being able to tell the patient that it's not a predictor of fertility in the general population, but it can give you an idea of your egg supply. And if you're going to be putting your family building on hold, it would be good to know your AMH level. So I do actually encourage OBGYNs to order it, and they should feel comfortable with it. But I also offer OBGYNs, if they order it for somebody and they don't know how to explain the results, that I'm happy to help them with that, and give them some information and counseling. And then I'm also happy to see patients too. But I think it's good to at least offer that for patients.
And then for patients or resident, whatever, I mean, some of it is your insurance is Cleveland Clinic and you're going to go to Cleveland Clinic, but there's a lot of transparency regarding IVF outcomes, with the SART and CDC data. With fertility preservation, how do we know where to go? It's just the oncologist will refer you to the game in town. Is it usually like that? Like, how many fertility preservations programs are there in the country? Are they really common in all the fertility centers, or how does that work?
Yeah, so not all fertility centers do fertility preservation, especially medical fertility preservation. And so one of the things that patients may look for is whether a fertility center works with Livestrong Fertility, because Livestrong Fertility is really the largest organization that can help patients with resources for fertility preservation. They actually can provide the medications for the IVF cycle or the egg freezing cycle that usually costs $5,000 to $7,000 per cycle for free. And so working with a clinic that has a relationship with Livestrong and has a contract with Livestrong is going to be one that does a lot of fertility preservation. And so many more smaller centers or centers that are non-academic may not be doing that.
I love that. Is it livestrong.com or livestrongfertility.com?
I think if you just do a Google search for Livestrong Fertility, it'll come up.
Cool. That's awesome. Well, thank you so much. I personally have learned a lot from this conversation. REI has advanced quite a bit since I rotated through in residency a long time ago. But also, I think this is great. So we can raise awareness, and I hope people will listen to this and invite Mindy for grand rounds at your oncology center and to OBGYN departments, because I think this is the point that you raised about people who feel like they missed out on the opportunity, have so much regret and depression. That would be me too if I missed my opportunity. And I could have had the opportunity to undergo these kind of therapies before undergoing cancer or radiation or whatever treatment. So I appreciate all your insights. And Dr. Christianson is at the Cleveland Clinic, and we appreciate all of your thoughts on this really important topic. All right. Well, we will see each other. I'm glad I got to see you today, and hopefully time does not pass so much so we have not seen each other in person. But we get to introduce our listeners to Mindy's insights. And is there any other online resources that people can go to learn a little bit more about this process?
So I think Livestrong Fertility is a good process for oncofertility. I think that resolve.org is also a good overall infertility and fertility preservation resource. Then also ASRM has excellent information as well.
Perfect. Thanks so much.
Thank you for having me.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orgoginski.
Show notes and social media by Emma Landenwich and Lindsay Beecham. Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers or any entities they represent.